Good morning. I'm Caroline Childs. We're going to move on to smoking-related lung disease. I live in a tobacco state, North Carolina, so I see a lot of smoking-related lung disease, as probably you do as well. So, not to overwhelm you with guidelines, this was the 2015 classification from the American Thoracic Society and the European Respiratory Society, classifying the idiopathic interstitial pneumonias. And I'm going to show you a close-up of this. So these are the two smoking-related idiopathic interstitial pneumonias, which to me is a little bit of a misnomer because if they're smoking-related, they're not really idiopathic. But nevertheless, these are the two, desiccative interstitial pneumonitis and respiratory bronchiolitis-associated interstitial lung disease. So these are the two that are included in this classification. So DIP, which has a lower zone peripheral predominance of ground glass attenuation, progressing on to lines and cysts, and then respiratory bronchiolitis, which is often upper lung predominant central lobular nodules. So let's go into more detail and show you some examples of both of these diseases. Now, in the topic of smoking-related idiopathic interstitial pneumonia, even though they do not include Langerhans cell histiocytosis in that, I'm going to throw this in here. These smokers do not decide they're just going to get one of these. There's often overlap, and people can have features of all three diseases on the same CT. So I'm going to go over all of these as smoking-related disease. So I think it helps to understand the histology, what's going on in the lungs when you're looking at these CT images, these high-resolution CT images, which can really mimic at least macropathology. So what the pathologist sees are clusters of pigmented macrophages. So they call these smokers' macrophages. Instead of having the sort of purpley look, they have a brown tint to them. And pathologists will see these in everybody who's a current and sometimes former smoker. They see them all the time. And on this slide, you can see some of these sort of brown-tinted macrophages within the lumens of distal airways and within the peribronchial air spaces. And then as the disease progresses, as the patient continues to smoke, you might start seeing an inflammatory and fibrotic response surrounding within the peribronchial interstitium. And that is going to correspond with what we see on high-resolution CT. So really, depending upon what your profession is, RB and RBILD appears to you as three different ways. So to the pathologist sees this top one. This pathologist sees smokers' macrophages in virtually all actively smoking individuals. But to the radiologist, what we see are ground glass, sort of fuzzy central lobular nodules with an upper lobe predominance. And then the pathologist sees a subset of those patients who are symptomatic. They have cough, exertional dyspnea, they have a mild to moderate restrictive ventilatory defect on PFTs, usually an impaired DLCO. And when they have this combination of signs and symptoms and PFT results, and in association with a CT that shows these fuzzy little ground glass nodules in the upper lobes, and in these patients who are typically current smokers, they're going to make the diagnosis of RBILD. So we don't make the diagnosis of RBILD, we make the diagnosis of RB, and then it's up to the pathologist to determine if the patient fits the pattern of giving them a diagnosis of RBILD. So again, sort of three different levels of diseases: smokers' macrophages in everybody, ground glass nodules in a subset, and then symptoms in a smaller subset of those patients. So here's just a distribution of the central lobular nodules. They're predominantly within the upper lobes, sort of hazy or ill-defined. And here's a CT, and if you look carefully, you'll see these little ground glass sort of nodules, which you can sort of imagine to be within the center of secondary pulmonary lobules, sort of peribronchiolar, and this is a typical appearance. And if you're in a place where you have a high prevalence of smoking, you're going to see this every day, unless your slice thicknesses are too thick. So sometimes I'll see a patient referred in with a CT from an outside facility, and the slice thickness on the lungs will be 5s. Now, I don't know if they're reading them that way. Maybe they kept the thin cuts for themselves. You're not going to see this on 5s. You're probably not even going to see it on 2.5 millimeter slice thickness. So we routinely will look at our lungs on 1 or 1.25 millimeter slice thickness, depending upon which CT scanners they're on. And that's going to give you this level of being able to see the finding and having confidence in what the finding is. Now, I will say we go back and do MIPS where we stack them up together and see thicker slices. And we're going to see features in other patients that are going to look more, we're going to be able to distinguish vessels from disease better. But for the most part, this is the bread and butter of being a chest radiologist, are these thin cuts. So here's another example where when you look closely, you can just see these little ground glass nodules. You can distinguish them from pulmonary vessels, which are separate and branching. We may see sort of patchy sort of clumps that create ground glass opacities. You may see bronchial wall thickening. And then sometimes you'll see a little bit of tree and bud. These will just branch a little bit. Again, strikingly upper lobe predominant. Now, one hesitation I make is if I have a patient come in for CT, for pulmonary embolism diagnosis, we blast them with this big bolus of contrast, and I'm going to see so much in the upper lobes. I sort of back off the diagnosis of RB in those cases because I'm afraid I'm seeing small arterioles. So I just take a little caution before I call it on a PE study. So I'm going to move on to the let me say one other thing about RB before I go on. Your differential diagnosis here is going to be hypersensitivity pneumonitis. Now, the good thing is that smoking seems to be somewhat protective from HP. So I just look at the history. If I'm trying to decide whether to call it RB or hypersensitivity pneumonitis, I just look at the history. If they're a current or recently active smoker, I'm going to go RB. So this pattern doesn't really completely go away once people stop smoking. It may improve, but it may not completely go away. Whereas patients with HP are usually never smokers, and then you can try to figure out what the exposure antigen is. Okay, so let's go on to DIP. And in DIP, the pathologist sees diffuse filling of air spaces by smokers' macrophages. And depending on the time course of the disease, you'll see variable degrees of fibrosis. So let's show you what that's going to look like on CT. The striking thing is it's peripheral and it's subpleural and there's ground glass opacity. You may see irregular linear opacities. You may see some cysts within this, but it's strikingly peripheral and subpleural. When it's not, sometimes I'll still consider the diagnosis, but I'm not as confident. In later stages, this is going to go on to be more of a fibrotic process. We'll see septal lines, traction bronchiectasis, architectural distortion, cyst formation as the disease progresses. But clinically, notice how all of this smoking-related lung disease presents pretty similar to the pathologist, to the pulmonologist. They all have exertional dyspnea, a dry cough. Now, this patient may occasionally have some weight loss and fatigue. There's an insidious onset. Patients are typically 20 to 50 years at onset, men 2 to 1. Distribution. Smoking history present in 90% of cases, but you can see this type of appearance with dust inhalation or some drug exposures. Clinical findings, rouse on auscultation at 60%. About half of patients will have digital clubbing. PFT is, again, a restrictive pattern. So unlike the patient who has central lobular emphysema is going to have an obstructive pattern, in DIP, you're going to have a restrictive pattern and a reduced diffusion capacity for carbon monoxide. So here's sort of a classic example. If I was writing an article on this, this is the case I would choose. This is, you can see how strikingly peripheral and subpleural this is. It's ground glass. And then if you look up closely, you'll be able to see some tiny little cysts beginning to appear in this. So this is sort of a classic example of DIP. And so you'll have a heavy smoking history, and you have the classic clinical pattern, and then you'll discuss with pulmonologist whether you need to go on to DIP, but it's pretty classic and should be able to treat without that. Here's another case that's not quite as classic. I see this ground glass opacity, but it's not strikingly peripheral and subpleural. And yet, in the absence of any other clinical findings, no evidence of infection to suggest an atypical pneumonia, heavy smoking history, this should be in your differential diagnosis for this patient. And then here's another one where it's a little bit more clearly subpleural. You're probably going to consider the possibility of NSIP in this, but this turned out to be a DIP on biopsy, and you can see this ground glass subpleural pattern. And perhaps a few little bit of lines in here as well. Now, this is another patient much further down the road. And so this is sort of the fibrotic form of DIP. And you can think of this in terms of the categories that Dr. Chung has just reviewed with us, where do you want to call this typical, probable, indeterminate, not consistent with? So when you look at this patient, you can see, well, you know, there is definitely some traction bronchiolectasis. I may not be able to call honeycombing, but I can see traction bronchiolectasis. There is a mosaic attenuation pattern, a lot of ground glass. And so this is a patient you might end up in your indeterminate category, and you might be thinking, I'm going to need to go to a biopsy. If, on the other hand, you can retrieve prior CTs that will show you more of a typical DIP pattern, then I think you could make a more confident conclusion that this represented a fibrotic stage of DIP and avoid a surgical biopsy at that point. Let's move on to Langerhans cell histiocytosis. Again, starting with the histology. And this is a beautiful picture from Jerry Abbott's article in Radiographics on Langerhans cell. But it took me a long time to understand what it was a beautiful picture of. So I'm going to explain it to you. So this is a bronchus sort of laid out end on. And these are 3 different levels and time points within the disease process. Because these patients started smoking back when they were teenagers and they continue to smoke, they have temporal heterogeneity. They'll have disease manifestations that are more acute, subacute, and more chronic. So you can see all of these findings in the same patient at the same CT, and so that's what can make this disease a little bit unusual in appearance. So in the beginning, there's a normal bronchus, and then the patient develops these discrete bronchiocentric stellate interstitial nodules separated by normal lung. And so at this point, here we have our nodule, and it may even completely obliterate the bronchus. And then over time, here we are where the nodules are replaced by a fibroblastic proliferation, and the fibrosis starts pulling this bronchus open into appearance of bronchiectasis or bronchiolectasis. And then even further down the road, the fibrosis can completely occlude the airway. We can end up with bronchiectasis and enlargement of the surrounding air spaces. And so we may see all 3 levels of disease in the same patient, or we may see just more of the acute process or more of the end-stage process. So let's look at this. So again, an upper lobe distribution, small nodules with cysts, and these cysts will look sort of like cavitary nodules. And I used to think they were cavitary nodules for a long time, but they're actually those the bronchi within the nodules rather than discrete cysts. So here's an example of a patient where we have these sort of stellate nodules. You can see they're just larger and more solid in attenuation than an RB. So you can be thinking about RB, but it's a little bit serious for RB. And then we have these cystic lesions as well. So again, you can see why, you know, for a long time, we've considered these to be sort of cavitary nodules. That's what they look like, but these are really distended air spaces and areas of discrete bronchiectasis because the fibrotic process is pulling that airway open. So this is a typical appearance of Langerhans cell histiocytosis. And you're going to see this quite commonly, not always this severe, but you may see a few manifestations. And it can get a little challenging when the patient also has some central lobular emphysema. So the central lobular emphysema has black holes that don't have discrete walls, whereas these have discrete walls. But here, as we get later in the course of disease, this is the same patient, what was that, 4 years later? Let's go. So this was 2007. This is 3 years later where we get, we're losing some of the nodules and we're just getting more of these thin-walled cysts. And you can see how irregular it looks because there is a fibrotic process. But again, upper lobe predominant. You might initially think about whether or not this patient has emphysema, but the walls of the cyst are just too thick for that. And here we are, another 6 years later, same patient with these thin-walled cysts. We're really not seeing the nodules. We're later in the course of disease. Patient may not be smoking anymore, and this is sort of the end-stage look of Langerhans cell histiocytosis. No biopsy is necessary. This is pretty classic. Here's another patient, and again, sort of this typical appearance on these multiplanar reformats. You can see the upper lobe and mid-lung preponderance of these stellate, irregular nodules, and irregular cysts. So notice that these air spaces are not always nice and round. They can be irregular looking, especially in more end-stage disease. So again, a typical appearance of Langerhans cell histiocytosis. Clinical presentation. All of these smoking-related people look the same clinically: dry cough, exertional dyspnea. Occasionally, they'll have fever and weight loss. About 15% will present with pneumothorax, and the age at onset, 20 to 40, and males involved equally as females. So if we look at the clinical findings, often the patient has no clinical findings. Occasionally, they'll have digital clubbing. PFTs can be anything. It can be obstructive because more of the air trapping is predominating. It can be restrictive because of more fibrotic process, or it can be mixed. But as with these other diseases, the DLCO is impaired. Another disease that has gotten some attention more recently is this concept of combined fibrosis and pulmonary emphysema. And the reason it's important for us as radiologists to know about this disease is that it's a confusing presentation to the pathologist. The pulmonary function tests are difficult to interpret. Because there's a combination of an obstructive component from emphysema and a fibrotic component from the basilar fibrosis, the obstructive and restrictive components sort of balance each other out, and yet they have a terrible diffusion capacity. So the pulmonologist doesn't really know quite how to put that together, and the CT can help with that. So again, dry cough and dyspnea, they all look the same walking in the door. The pathologist may report a combination of emphysema with either a UIP or an NSIP pattern, or they may just report out a combination of fibrosis and respiratory bronchiolitis because they're seeing these smokers' macrophages. On imaging, we see emphysema in the upper lobes, as typical, and we'll see lower lobe fibrosis with preserved lung volumes. So although the lung volumes might be large with emphysema alone, small with fibrosis alone, they balance each other out, and we get sort of normal lung volumes. So the prognosis is better than the dismal prognosis of UIP, but it's worse than if they just had emphysema. And it's worse if they also have pulmonary arterial hypertension. The risk of lung cancer is very high, and as with some of these other diseases, the diffusion capacity is severely reduced. So this, again, confusing on the basis of PFTs alone, and the CT is pretty straightforward. You're like, what's your problem? This is sort of obvious. So here's an example of one, chest X-ray. You can see that although we can recognize this fibrotic pattern at the bases, the lung volumes are preserved. Most of our patients with a fibrotic lung disease, you're going to see shrinking of those lung volumes, those diaphragms coming up. And when we look at these multiplanar reformats, a typical appearance of central lobular emphysema in the upper lobes combined with a fibrotic pattern at the bases. And you can see why they balance each other out in terms of the obstructive and restrictive component on pulmonary function tests. So that's just one disease to be familiar with, even though it's really two diseases stuck together. Okay. I wanted to make sure we had a little time to talk about this new thing we're seeing, which is vaping-related lung disease. So this has the unfortunate name of EVALI, e-cigarette vaping product associated lung injury. And this just appeared on the scene this summer, but how many people have seen a case of EVALI at their institution? Okay, so many of you have seen this. This data is from the end of October when there were 1,600 lung injury cases, but many more have been reported since then. At that time, there had been 34 deaths, 70% male distribution, median age of 24, and about 3/4 of the patients had reported using products containing THC. One of the current theories is that these pods that patients are using they've put vitamin E as a filler to sort of thicken the stuff that they're vaping, and that may be the whole reason for this disease. But not all patients report using THC. So when you encounter a case like this and you think it's vaping-related lung disease, you notify, well, we don't, but somebody notifies the public health department. They go to the patient's house, they collect the pods, and they take that from there to figure out what is responsible for this. They're really trying to nail down the causative agent here. So this is when the disease started. So you can see that it trickle of cases in June really started becoming a national problem in July, and then going up through August, September, and at this time I did not have the more recent, but you can imagine this is an upward slope. Despite what's known, what the media are covering, we're still seeing cases of this EVALI. So the symptoms are confusing. At first, when I had read about it, I thought, oh, well, they walk in, they're short of breath, they say, I've been vaping. It's going to be straightforward, but it's not straightforward at all because they have systemic symptoms. They don't just have cough, shortness of breath, chest pain. They have these systemic symptoms of nausea, vomiting, abdominal pain, diarrhea, fever, chills, weight loss. You think they've got an atypical pneumonia, that they walk in seeming like they have an atypical pneumonia. The symptoms may have developed very acutely over just the last few days, or could have been more insidious and coming on over weeks. But these systemic symptoms really take the clinicians down a different path. So when they come in the ER, they're going to initially think that this person is infected. Now we know a lot more about this, and so we're a little bit better. But in September, the CDC issued these guidelines for confirming the definition. They said that they had to have used an e-cigarette or vaping product within the last 3 months prior to the symptoms onset. That's a pretty big window. They have to have an abnormal chest X-ray or chest CT showing opacities. You have to exclude pulmonary infection. Because these mimic an atypical pneumonia, we need to make sure that all the viral panels, the influenza PCR is negative, all other testing for a respiratory agent is negative. And then you have to have no good reason to call it something else. And if all of that, basically they come in, you think it's atypical pneumonia, they start them on a broad spectrum antibiotic or antiviral, but they're not responding, you never recover an organism, but then you get that history of vaping. So I'm going to show you the first case we saw. So this was a 23-year-old woman, I think this was end of July, and she had fever, chills, myalgia, dry cough, increasing dyspnea, tachycardia, and she had this history of Juul use. This was her chest X-ray on admission. No matter which way I look at this, it comes back normal to me every time. I can't see anything on this chest X-ray. This is her CT 3.5 hours later. And now you can see these areas, these patchy areas of subpleural ground glass, maybe even more frank consolidation here. It has a pattern that sort of looks like an organizing pneumonia pattern to me, but this is acute illness. And so, as you can imagine, we read it out in late July as suggestive of an atypical pneumonia. The clinical pattern with these systemic symptoms, this chest CT looked like an atypical pneumonia. And this is just our multiplanar reformat showing you this very peripheral distribution of disease in this patient. This is 48 hours later. That chest X-ray has gone from normal to abnormal, and you can see now the corollary of what we were seeing on the CT. You could imagine now what was ground glass is going to be more frank consolidation with more of a basilar predominance. At this point, this patient's getting pretty sick and is being moved to the intensive care unit. And this is 72 hours after admission, and you can see she's intubated. We probably need to pull that endotracheal tube back, but she is very sick, and they're calling in the clergy and her parents and thought we were going to lose her. So she was very, very sick. And at some point, they start piling on the steroids, and the steroids are what's going to help reverse this inflammatory process. So here's the recommended management. Well, you have to treat for everything else you think could be going on, which is predominantly, you think about infection. And it's interesting that the physical exam is pretty unremarkable. Now that they're coming into the ER and they may not be as sick when they first present, they basically say you've got to admit if their oxygen sat is less than 95% because they could go downhill very quickly. Consider an empiric use of a combination of antibiotics, antivirals, or steroids. And then you want to follow up very quickly after discharge because they can have some other complications. So she comes back 3 days after discharge. I think she was in the hospital for about 2 weeks, and 3 days after discharge, she comes back with crepitus on her physical examination. So at this point, she was discharged with a pattern that was sort of a resolving ARDS pattern, but now she has pneumothorax, subcutaneous emphysema, and came back into the hospital to make sure that we could manage that. So you can see because of this sort of ARDS pattern, she had developed these cavitary and bullous type lesions, which rupture and give her the pneumothorax, and you can see her pneumomediastinum as well on this CT. This is just a multiplanar reformat showing you sort of a resolving ARDS pattern. This is almost 3 weeks after her admission. We brought her back in the hospital, discharged her again, and this is a week after that. Again, just sort of slowly resolving ARDS. Not sure what we're going to see down the road. My expectation is she's going to be like some other ARDS patients we have, end up with sort of an obstructive bronchiolitis obliterans type picture. So this is what she's looking like now. I would think her lung function will always be abnormal. So the pathology at that time, and we had our own pathologist read it, and we sent it off for expert pathologists. The path report wasn't that helpful. The differential is quite broad. That's always a bad sign. I can give you a broad differential. I need something specific from the pathologist. It could be anything, but they did add in this particular patient, since we told him she'd been vaping, it may be that vaping THC is responsible. So that was our very first case. This was the next case. We were smarter. This patient came into the ER, very similar picture. Could have been the younger sister of the first patient. 22, myalgias, fever, chills, nausea, vomiting, history of vaping. Chest X-ray, maybe a few little patchy areas, but again, hard to call. And then 2 days later, you can see her chest CT has these patchy areas of ground glass attenuation. Again, with the clinical picture, and with the CT, it would be perfectly reasonable to think this is an atypical pneumonia, but now we have to add vaping-related lung disease, or EVALI, to that differential. So CDC recommends a chest X-ray in all patients with a history of e-cigarette use and who have respiratory or GI symptoms, particularly when accompanied by an oxygen saturation of 95%. It's pretty high threshold, 95%. It's not that low, but you just have to have a very high index of suspicion when they come in and tell you. And be quick to go to CT. Even if the chest X-ray is normal, you want to be quick to go on to CT because it will show you findings that that you won't see on that chest X-ray, and will help keep, I think, the clinicians on top of the potential for rapid deterioration in this patient. So I was trying to figure out a conclusion slide for tying all of these together. Before I do that, let me show you this. This is one article that was published online in October. Travis Henry is the lead author, Imaging Findings of Vaping-Associated Lung Disease. It's going to show you some more examples, and some of these were obtained really before the epidemic and probably are related to the vaping itself and not necessarily to this more recent THC-associated injury. And also the very similar slide collection is on the website for Society of Thoracic Radiology, thoracicrad.org, so if you want to look at some examples. And they report that there are many imaging patterns. Again, the ones I've seen sort of look like organizing pneumonia. I think lipoid pneumonia is within that, acute lung injury, diffuse alveolar hemorrhage, and even a hypersensitivity pneumonitis has been reported prior to this sort of THC phase. So here's my conclusion. Smoking's bad for you.